In this session, we are going to discuss the pain disorders associated with eye and neuro-ophthalmology, and we are going to discuss them under three broad headings: headaches, facial pain, and ocular and orbital pain. Headache is a very frequent complaint of patients attending an ophthalmology clinic, and headaches can be classified as primary headache syndromes, which include migraine, cluster, and tension type headaches. When the headache occurs due to other pathologies, it is called secondary headache. Headaches referred to the ocular region from a cause in some other location can be assumed to be due to the eye by the patient. Taking a good history usually helps us in diagnosing the majority of headaches. In the majority of patients with headaches, ophthalmic examination turns out to be normal. Examinations which may be required in a patient complaining of headache includes blood pressure, which must be routinely checked or at least inquired about in a patient complaining of headache, and which we often omit to do. Tenderness over frontal and maxillary sinuses should be checked, and this indicates sinusitis, a common cause of facial pain and headache, and we must look for abnormalities in the appearance of the disc, such as disc edema, cranial nerve dysfunctions, abnormalities of the temporal arteries in the form of thickening, tenderness or pulselessness, and neck stiffness. Investigations which may need to be done in patients complaining of headaches include ESR, CRP, and platelets, which must be done for every elderly patient suspected of having giant cell arteritis, visual fields and neuroimaging in appropriate situations. So what are the indicators of a benign headache? A long history of similar headaches, headache-free intervals between episodes. For unilateral headache, episodes involving either side, that means in some episodes the right side of the head is involved and in other episodes the left side of the head is involved. Absence of focal neurological signs and symptoms other than aura, and a gradual onset of headache during an episode. Starting with secondary headaches, giant cell arteritis is a very important cause to consider in elderly patients, and we have discussed it previously, but we'll go through it once more. Patients may complain of fatigue, weight loss, fever, and polymyalgia, and on examination we may find scalp tenderness, and temporal arteries may be thickened, nodular, tender, or pulseless. Jaw claudication is a highly specific symptom of giant cell arteritis, and on examination of the blood for ESR, C-reactive protein, and platelets, they may be found to be elevated, but they may be false negative in as many as 20% of patients. Ocular symptoms of giant cell arteritis includes transient visual loss, arteritic AION, retinal artery occlusions which may involve the ophthalmic artery, the central retinal artery or branch retinal artery, and cranial nerve palsies. And if any elderly patient presents with any of these four signs or symptoms, giant cell arteritis must be excluded. Headache in raised intracranial pressure is global, that means the entire head is involved, is constant, and is worse in the morning. And the headache is increased by bending forwards, moving the head, or by Valsalva maneuvers like cuffing and straining. Patients may have vomiting with or without nausea. Pulsatile tinnitus is a very important symptom of raised intracranial pressure, and we must inquire for this symptom when we suspect raised intracranial pressure. Ocular symptoms of raised intracranial pressure includes transient visual loss which lasts for seconds, papilledema, and 6 cranial nerve palsy which may be bilateral. Intracranial hemorrhage, such as in pituitary apoplexy, causes sudden severe headache with altered consciousness. Ocular findings may be loss of vision and palsy of the 3rd, 4th, 5th, and 6th cranial nerves. Pituitary apoplexy is a sudden onset hemorrhage or necrosis in a tumor within the pituitary gland. Internal carotid artery dissection can present with headache along with pain in the neck and the facial region. And typical ocular sign of internal carotid artery dissection is Horner syndrome because the third order sympathetic neurons travel along the internal carotid artery. In meningitis, we have headache along with stiffness of the neck and pain on flexing the neck. Back pain may also be present in headaches associated with meningitis. Meningitis patients may not have associated focal neurological deficit, and typically patients with meningitis complains of photophobia and may also complain of pain on eye movements. Now we come to primary headaches, out of which migraine is the most common, and it can be present in up to 20% of the population. And migraine has a diagnostic criteria which requires at least two of the following characteristics: a unilateral headache at least initially in the episode, but later in the episode the headache can become global. The nature of the headache is pulsatile. The headache is moderate to severe. It impairs physical activities. So at least 5 headache episodes with any two of these 4 criteria, with each of the episodes lasting 4 to 72 hours, is required for labeling a patient with migraine. Associated symptoms of migraine is nausea and vomiting, and nausea and vomiting does not belong to the diagnostic criteria for migraine. Photophobia and phonophobia may also be there. The headache may be bilateral, symmetric or asymmetric as we have discussed, and the migraine and the associated aura usually changes sides with episodes. That means in some episodes the headaches occur on the right side, and in the other episodes the headaches occur in the left side. Ocular symptoms of migraine include ocular or periocular pain, photophobia and aura. Aura occurs in 35% of migrainiers. 5% of migrainiers may have only aura without headaches. Now these patients usually have a history of migraine with aura. They may have negative visual phenomena such as homonymous hemianopia and peripheral constriction of visual field, and thus they need to be differentiated from more serious causes of transient visual loss. Less commonly, the aura can be non-visual, such as hemiparesis, hemianesthesia and dysphagia, and then again they need to be differentiated from serious causes producing transient ischemic attacks with these symptoms and signs. Other ocular signs and symptoms is palinopsia, that is persistence of after image after the object is removed from the visual field, visual snow, which we have described in the session on disorders of visual perception, metamorphopsia, micropsia, macropsia, pelopsia and telopsia. Diplopia can occur with migraine of the brainstem. Anisocoria may also occur with headaches in an entity called benign unilateral episodic mydriasis, and dry eye is found to be associated with migraine. Now migraine with aura-like episodes may occur with occipital AVMs. But in occipital AVMs, in contrast to migraine, headache is located only on one side of the head in each episode. The aura occurs for a shorter time than in migraine, and the aura continues after the headache starts. Pointers to a more serious etiology instead of migraine is a new onset headache after 50 years of age, change in character of the headache, presence of associated signs and symptoms such as hypertension, neurologic deficits, papilledema, visual field defects, neck stiffness and altered consciousness. These do not occur with migraine. History of malignancy, visual symptoms persisting or occurring after headache, headache triggered by physical activity, postural changes like bending and Valsalva maneuvers like cuffing and straining, and sudden onset of a severe headache called thunderclap headache. In contrast, headache in a migraine episode is initially mild and then gradually intensifies. Ophthalmoplegic migraine, which we have covered in the session on third cranial nerve palsy, and retinal migraine, which we have covered in the session on transient visual loss, are migraine variants, and we are not going to discuss them further in this session. Tension type headache is another primary headache syndrome in which bilateral headache occurs and the headache appears to press the head tightly all around like a band, and it is non-pulsatile in nature in contrast to migraine. It is precipitated by stress and fatigue. In tension type headache, there is no intolerance to physical activity. Nausea, vomiting, photophobia and phonophobia are absent, and prodromal symptoms like aura is also absent. So all these are features of migraine type headaches. Trigeminal autonomic cephalgias are a group of primary headache syndromes, and we must not confuse this term with trigeminal neuralgia, which are characterized by unilateral headache associated with conjunctival injection, tearing and rhinorrhea. In clustered headache, the recurrent episodes lasts from 15 minutes to 3 hours and is characterized by excruciating retroorbital pain. Typically, the episodes occur in a cluster lasting from 4 to 12 weeks, followed by a headache-free interval for months to years. During the cluster, the episodes occur at least once daily and almost at the same times every day, and the clusters have a tendency of repeating at the same time of the year. The episodes usually involve the same side, which is atypical of a primary headache, and it may be associated with transient postganglionic Horner syndrome. There are other headache syndromes which are classified under trigeminal autonomic cephalgias, and they usually vary in the duration of their episodes and the frequency of repetition. Idiopathic stabbing headaches are typically described by the patient as ice pick or jabs or jolts kind of headaches, and these are momentary stabbing headaches, and they occur in patients with migraine, cluster, as well as other headache syndromes. Now there are genetic disorders associated with headaches such as MELAS and CADASIL. Coming to ocular and orbital pain, among the causes listed here, a few have already been discussed in previous sessions, and the rest will be discussed in their respective sessions. Ocular causes of pain include dry eye, keratitis, recurrent corneal erosion, angle closure glaucoma, iritis and scleritis, demyelinating optic neuritis, and even microvascular cranial nerve palsy can be associated with pain. Orbital causes of pain include cellulitis, a rapidly expanding orbital tumor, or trochleitis. In trochleitis, there is a long-standing localized orbital pain with tenderness and swelling in the trochlear region. It occurs predominantly in women. It may be idiopathic or associated with autoimmune diseases, and it is usually underdiagnosed. Facial pain can be referred to the eye, and we are going to discuss facial pain in the next section. Here we will briefly go through the causes of photophobia, and they include many of the ocular and orbital causes of pain. In addition, meningitis, migraine and traumatic brain injury may also cause photophobia. Coming to causes of facial pain, sinus headache is the most common and trigeminal neuralgia is the most well known. Now, primary trigeminal neuralgia must be differentiated from secondary trigeminal neuralgia, and primary trigeminal neuralgia occurs due to vascular compression of the root of fifth cranial nerve by superior cerebellar artery. Trigeminal neuralgia usually involves the second or third division of the trigeminal nerve, and it rarely involves the first division of the trigeminal nerve. The pain in trigeminal neuralgia is short-lasting, less than 2 minutes, and often occurring serially over several minutes. And the patient describes the pain as stabbing in character. The pain in primary trigeminal neuralgia can be provoked by chewing, toothbrushing, light touch to the face, or exposure to cold wind. Although the trigeminal nerve is involved, facial sensation is intact. Secondary trigeminal neuralgia usually arise from neoplastic processes, and the episodes of secondary trigeminal neuralgia are longer lasting and are of moderate severity. In contrast to primary trigeminal neuralgia, in which the sensation from the face is normal, in secondary trigeminal neuralgia there is abnormality in facial sensation in the form of dysesthesia and hypesthesia. Sinus headache is probably the most common form of facial pain, and we find pain and tenderness over the frontal and maxillary area. And patients usually give a history of sinusitis and or allergic rhinitis. Other causes of facial pain include herpes zoster, ophthalmicus and herpes zoster oticus, and herpes zoster is associated with vesicles. However, there is an entity called HZO-sign herpet in which there is a typical pain without vesicles, and post-herpetic neuralgia after the skin eruption occurs in 30% of patients with herpes zoster. Internal carotid artery dissection and giant cell arteritis have been discussed earlier, and they may present as predominantly facial pain. Thank you for listening.